positive and a negative. The ECG machine, EKG machine does not have to create a negative force built in. All right, now, when we look at the bipolar limb leads and how they are set up and how they're attached, we talked about limb leads being attached up here by the arms and down by the hip area, lower abdomen. Lead one comes across on the top, meaning if we look here, our positive electrodes, or the positive part of the electrode, we stick it on there, and that is going to be on the left side. Positive is on the left, okay, and negative is on the right. Again, in those electrodes, you don't know that. You don't know, you can't look at the electrode, and the electrode says this is a positive, this is negative. What it's going to say on the lead, which is the wire that goes to the electrode, it's going to say left leg, left arm, right arm. Okay, or it says R-A-L-A-L-L. That's what it says. And we know by virtue of the machine, the way they're set up, if it says left arm, then we know by left arm, we know that, okay, set up correctly on lead one, I'm going to have my positive is going to be on the left arm, and my negative is going to be on the right arm. And the reason why that's important is because that positive part of the electrode, that's how that lead is looking at the heart. Meaning, if my lead one and my positive is on the left, then what part of the heart is that lead one looking at? The left part of the heart, because that's where the positive is at. And that's why it's important to know that. But even though the electrodes are up here, it doesn't mean that the ECG machine is reading the heart from up here. The heart doesn't even exist up here. The heart's down here. Right? That's just how the electrodes are placed. And by design of the ECG machine, okay, it's able to bring the view down through the middle of the heart. The electrodes are placed up here, but it can see the middle of the heart. It's looking from the left side over because that's where our positive is. So the lead one, positive on the left, negative on the right, and it comes down through the center of the heart. Okay, lead two. Okay, lead two, again, aligns with our normal electrical axis. Lead two, we have a negative on the right. We have a positive on what we call the foot or the inferior. Okay, positive down here. And if I say a positive, and we're talking about our limb leads, okay, and I'm telling you that it's going down here somewhere, where is it going? Is it going over here to the right, or is it going over here to the left? It's going to the left, because the right is our interference. Right is our interference. So positive is going to be down here, and negative is going to be here. Again, it's not looking way over here on this side of the heart, and when we come here, it's looking right down through the middle of the heart here, from the top to the bottom, where one looks from left to right. From the top here to the bottom. And because this positive is down here, okay, down on the left lower, what part of the heart then is it looking at? It's the inferior, but the underneath, the bottom part of the heart. Okay? And then lead three also looks kind of in the middle of the heart, but yet now it's going from left to right, which is left. So we have our negative electrode for lead three is up here on the left, and our positive is down on the left. You can see the angle comes down this way, and it looks at the heart from here. Again, that positive down here at the bottom, so what that means is for that lead, it's looking at the inferior portion. The way that these are determined is we put this where the positive is at. The positive is here, okay? And this looks through the heart here, and this looks through the heart here, and we've got a negative looking through the heart. Okay, so we're going to go through each one of these leads. And each one of these leads, when we go through it, at the end of going through this lead, you'll understand why we have positive and negative deflections, why do we have a flat line, why do we have kind of a curve. So let's start with lead two. And again, we use lead two because lead two most aligns with the normal electrical axis. electrical access is going to go up from the SA node in the right portion, right atrium, down and to the left, because the left ventricle is pulling that electrical activity down. That depolarization is going down toward the left ventricle. We talked about the left lead 2. When we talked about lead 2, we said the negative is up on the right, and the positive is down on the left. So it goes down through the middle of the heart, canted a little bit to the left, because it's following that normal electrical pathway. So this is going to be our lead 2, our apex down here, and we've got the top portion of our heart. So depolarization is going to begin at the SA node. The SA node is located in the right atrium. Everybody agree with that? SA node, right atrium, and that's where depolarization is going to begin. And it's going to begin because of automaticity that's associated with those pacemaker cells. Okay? So when we have depolarization that starts from the SA node, it's not going directly down to the AV node. Right? There's other parts of that atrium that have to depolarize. So you've got depolarization that's going all throughout. It's going for the rest of the right atrium. You've got depolarization that's going over here through Bachman's bundle, over here to the left atrium. All of those cells are depolarizing. But what the EKG machine picks up is the majority of the depolarization. And the majority of that depolarization is going to be going down towards that SA node, because the left ventricle is pulling everything down. Ultimately, it's going to get down to that left side. We've got that electrical vector, even though we have a whole bunch of vectors that are going out, the majority, the main electrical vector, the majority of that pull is going to be from the SA node down to the AV node. And then the rest of this area is going to be depolarized myocyte to myocyte. When we have depolarization of the atria, that is the first wave that we see on our ECG machine. First wave that we see of the ECG is the depolarization of the atria. And that is called our P wave. Our P wave is slightly rounded. It's slightly rounded. And that signifies both depolarization of the right atria and the left atria. Now, we typically cannot tell which part of this P wave is the right atria or left. Like usually, it's just one smooth round. But when we talk about atrial problems, the right portion of the atria is the first part of the P wave, and the left atria depolarization is the latter part of the P wave. So if there's something wrong with the atria, we're going to see it in that P wave. Maybe one atria is bigger than the other. We're going to see it in the P wave. Right, so if we're looking, if we see, why does this P wave, why does it not look nice and rounded? Why does it look like it goes up a little bit and then round? There's something wrong with the atria. There's something in the atria that is causing that. That's our first wave that we're going to see. Right now, we have still, this is going to be redundant for a reason. So for those of you who are well versed in EKGs, I apologize, but it's redundant for a reason so we can get the idea down before we move on. Okay, so we're going to start from the SA node. We're going to go down to the AV node, right? We have that depolarization of the P wave, atrial depolarization, and that is our P wave. At the AV node, we have those calcium channels that are open, but those calcium channels are just slow going, right? Because we want a little bit of delay, so we have a delay from depolarization of the atria down to the ventricles. So what happens is then the ECG machine picks up that slow movement as no movement of electrical activity at all. It says that I can't capture anything moving down towards the left, okay, or moving anywhere. And when you don't have electrical movement, it's a flat line. Flat line. So that flat line that we have after the P wave is considered our PR segment. And it specifically denotes that area around the AV node, okay, where we have a delay in the electrical conduction. Just, like I said, just a little 0.1 second delay. 0.1 second delay. So that we allow the atria and the ventricles to depolarize at different rates. Okay, has everybody got me so far? We got the P wave, atrial depolarization. Start from the S8 now down. At the AV node, we have initially no electrical movement. So because we have no electrical movement, that's going to be our PR segment, and that's also considered the baseline of the ECG. So as we move on, we say, okay, when we move on over to the ST segment, the ST segment should line up with the PR segment because it's our baseline of our ECG. Okay. After we have depolarization at the AV nodes, we have our SA node down to the AV node. We have our P wave, which signifies atrial depolarization. At the AV node, we have that slight delay. Okay, so we're going to have that PR segment, no net movement. So that means we have flat. So it's our baseline. That's our flat line. After that, we have to continue on with our depolarization. Okay, we've got our bundle of His. Okay, we're going to go down to the bundle of His. Off of the bundle of His, we have two bundle branches. We actually have three. Okay, we have on the left side, we have two, and on the right side, we have one. But we consider right bundle branch and left bundle branch. So we're going to come down beyond our bundle of His, and we're going to start to depolarize those bundle branches. The right bundle branch and the left bundle branch are going to start to depolarize. If you look over here on this image on the side, and you can see the two branches of the left bundle, and you can see one branch of the right. Well, this top branch of the left bundle branch specifically goes across that interventricular septum. And so it is responsible for then depolarizing the interventricular septum. So that septum, that muscle area between the two ventricles, it depolarizes that area specifically. So that left bundle branch, part of that left bundle branch is responsible for depolarizing the interventricular area. That interventricular area, okay, we got our P wave here, down, we got our PR segment, we've got depolarization, okay, of these bundle branches, but it's that left bundle branch that is going to depolarize the area, and so our electrical vector is going to be moving here. Now, when we look at this, okay, if we look at this P wave, okay, why do you think this P wave is upward? Why isn't the P wave down going? The electrical conduction is towards the positive. Remember that one slide I said, this is chaos on this slide? You go, what is she talking about? This is what I'm talking about. When you have positive going towards a positive, electrical conduction, okay, we have depolarization going towards a positive, it's going to give you an upright deflection. Here we have no net movement, so we have a flat deflection. All right, when we go to our left bundle that is innervating the interventricular septum, and we have depolarization that's coming this way, towards the right, where are those arrows pointing? Are they pointing towards the positive, or are they pointing towards the negative? So here's where you have to leave your type A personality away. Oh, put it away. Because you're like, it's not pointing towards anything, right? Well, it isn't, but it is. Because the heart is canted a little bit in the chest wall. It's canted a little bit. And we know that positive is way over here. I want you to think about negative being up here and this side, and positive is kind of just over here. Okay, so if we have these going this way, well, they're definitely not going towards the positive, because the positive is the opposite of that. Positive's over here. But we have depolarization, which means the interior of those cells is what? Positive. So positive going towards a negative. What deflection are we going to have? Positive going towards a negative is a negative, just like that. Okay, so our next deflection, when we have depolarization of the interventricular septum, is our Q wave. Q wave is down going, because we have depolarization, okay, so positive internal cells that is going towards a negative electrode, and that's going to give us a downward deflection in that Q wave. So Q wave represents interventricular septal depolarization. And it gets depolarized from the left bundle branch by way of anatomy, okay, by way of anatomy and how the heart is designed. Because it gets depolarized from the left, going left to right, we're going towards that negative, we have a downward deflection. Okay. So we've got our P wave. Our P wave is upright because we have positive depolarization going down toward a positive. PR segment, we have no net movement, so that's going to be flat. So we come down, we have depolarization of that interventricular septum. It's going towards the right. We have negative over here, so that's going to be our downward deflection. Our Q wave comes down, it comes back up to baseline. Now we have to talk about depolarization of the rest of the ventricle. We've got interventricular septum, but we've got to depolarize the rest of the ventricle. Now, again, we have a lot of myocytes. Each one of those myocytes is going to depolarize some areas and become more positive. From a negative resting state to positive, so we can have contraction occurs as part of that depolarization. So we've got movement, net movement here, all over the place. The right ventricle, it's pulling a little bit over there because it's got a little bit of muscle, okay? The left ventricle, though, is much bigger. So the left ventricle is really pulling a lot of that electrical conduction, a lot of that depolarization. Everything's going to get depolarized as long as the heart is functioning right, but it's really pulling that left, pulling to the left. And so what that means is if we equal out between a little bit of the right and a lot of the left, okay, we're going right down towards that positive electrode, right? Because we take the sum from this and this, and it brings us right down towards that positive. So if we have depolarization here, going down towards this positive electrode, what is our next portion of the EKG? What is it going to look like? Positive or negative? Positive, right? So we have positive. We got positive going towards a positive. We have this upward deflection, okay, and it comes down, but it's upward. It comes back down to baseline, and that is our R wave. And R wave represents depolarization of the ventricular apices, okay, of the ventricular apices. So the apex of the ventricles are being depolarized, and because it's going towards a positive, we have that positive deflection. Okay, so we still have our P wave. Why, when we look at the P wave, okay, go back a little bit. When we look at the P wave versus look at why is the P wave kind of rounded, but the R wave goes up and down? Anybody know? Magnitude. So the atria are kind of small. They don't pull a lot of electrical activity. Anyway, they are depolarized, but they're kind of small. So when they depolarize, it is kind of, we're depolarized. But when the ventricle is depolarized, you know it. Okay? If anybody here has ever had a PVC, a pre-ventricular contraction, maybe you've had it, you know, I bet you've had it, especially if you that's that, like, oh, I feel like my heart is beating in my throat, it's really hard in my chest. When the ventricles beat, you know, it's very quick for the ventricle depolarization, so it's up and down. Where the P wave doesn't pull as much electrical activity, the atria don't pull much electrical activity, so we have more of that rounded P wave. Okay? So here we've got our P wave, we've got our PR segment, which indicates no net movement. We got our Q wave. Remember, our Q wave is interventricular septal depolarization. Okay, we've got the depolarization of our ventricular apices, or apex of the ventricles. Okay, that's that R wave. Once we have depolarization of the apices, are we done? We're not. And the reason why we're not is because we still have to depolarize all the way up here, the ventricular bases. So our Purkinje fibers go all the way up. Okay, not up to the atria, but they have to cover the sides of the ventricles as well. So we've got this portion based on our R wave. Our R wave, it represents depolarization of our apex, we've got to have something that represents depolarization of our bases. Okay? So when we have depolarization of our bases, okay, we've got electrical activity coming up this way, we have electrical activity coming up this way. That's depolarization, so that means the interior of those cells is positive. Where is it going? What is our next deflection going to look like? Up or down? It's going to look down because we have positive going up here towards the negative. Positive going towards the negative. Okay, positive going towards the negative. Our next deflection is going to be downward, and that is our S wave. And our S wave represents depolarization of the ventricular bases. Okay? The depolarization of the ventricular bases. That is our S wave. So we've got our P wave for atrial depolarization. Our PR segment is going to be at that AV node. We've got our Q wave, depolarization of the interventricular septum. Okay? R wave, depolarization of the ventricular apices, and now we have our S wave, depolarization of the ventricular base. Very good, very good, very good. So still going to SA node to our AV node. We've got our AV node that's coming down. Depolarization of the interventricular septum going towards the negative, so we have downward deflection. Okay, and then we've got our R wave, which is going towards the positive, so it's an upward deflection. We've got our bases that are depolarized. What happens next? We got to have repolarization. But between depolarization and repolarization, the heart takes a slight break. Slight break. We have no movement of electrical activity. If I tell you we have no movement of electrical activity, how is that going to represent our EKG? Flat. Okay? That's our next. Our flat. And our flat represents our ST segment. So as I said before, PR segment is our baseline. Our ST segment should be in a line, for the most part, with our PR segment. And when it's not, we get concerned. We get concerned about ischemia. We get concerned about infarct. Okay? So these technically should be aligned. There are variances that are normal variances, but just think about this kind of being one line that comes across. So that's our ST segment, no net movement. And then after ST segment, then we're going to roll into repolarization. Okay? So we've got our P wave that comes around. Okay? We've got positive because it's going towards a positive. We've got our PR segment, no net movement. Our Q wave, depolarization of the ventricular ventricular septum. We've got our R wave, depolarization of the ventricular apices. We've got our S wave, depolarization of the ventricular apices. And then our ST segment, which is between that depole and repole. Next thing we have to do, remember at this point, the interior of the cells are what? Positive. They're positive because we just finished our depolarization. So now those cells are going to start to flip and become more negative. They're going to go back to their resting state. Okay? And our repolarization is going to start down here, so really at the bases, come to the apex and go back up. That's how we're going to do that rest. Okay? So we go back up and we're going to start resting. So if we have repolarization, we go positive, negative, positive, negative. The interior of those cells are becoming more negative, and it's coming back up this way. What does our next deflection look like? Negative going toward a negative is positive. So that is our T wave. Okay, that is our T wave. Is going to be representing our repolarization. Okay, remember, in math, positive plus negative plus a negative is a positive. So T wave is that repolarization. So if we have something going on with repolarization, okay, maybe one of those electrolytes is off, it's going to affect how the body repolarizes. We're going to see that in the T wave. More commonly in our T wave is hyperkalemia or hypokalemia. So increased potassium or low potassium. Oftentimes we'll see that in our T wave. It really does affect our T wave as we try to repolarize. Because remember, repolarization, what's happening is our potassium is doing what? Leaving the cell so that that cell can become more negative on the interior. So as it's leaving that cell, can affect that T wave. And again, repolarization doesn't take a lot of electrical energy, and so that's why it looks similar to our P wave. We have that rounding inside that. That's our positive going towards our negatives. All right, so when we look at the summary of lead 2, okay, we've got our P wave. P wave is upright because it's going down towards the positive electrode. For lead 2, negative electrode is where? Right? Positive is left. Coming down like this. Coming down like this. P wave, HO depolarization. We've got our PR segment. PR segment is AV node, right? No net movement at the AV node. That is also called our basin. We've got our Q wave, depolarization of the interventricular septum. After that, we have the R wave, which is our depolarization of the ventricular basis, and it's upright because it's going down towards that positive electrode. We've got our S wave. S wave is depolarization of what? Of the ventricular basis. Okay? And then our ST segment, that slight pause between dipole and repole. T wave is repolarization. That is what lead 2 looks like. Okay? All right, let's do a couple of knowledge legs. Let's see what you remember since the break. Livingston. Okay, sir. AV node. If AV node is a pacemaker of the heart, what's the normal rate for AV node? Or junctional area? 40 to 60. Everybody agree with that? 40 to 60? Sir? Okay, 40 to 60, that is correct. Mitchell. Jesse Mitchell? Okay, sir. Which of the following ions is responsible for cell-to-cell depolarization? Sodium. Okay, sodium is it. Cell-to-cell. Now, sodium is responsible for other things as well, right? But cell-to-cell depolarization is sodium. Very good. Castleberry. Oh, okay, there you are. Which of the following has the fastest pacemaking function? SA no, because it is more permeable. Now, that was on you, because that was pretty good. All right. Cardiac cell is polarized in the normal resting state with a positive internal charge. Resting state, false, right? That's false. True. All right, very good. Now, Daniels. Okay, sir, here we go. 78 or female. Unresponsive, has a heart rate of 38. That's all you know. Where do you suspect she's being paced from? From the ventricles, right? Because what is the rate for the ventricles? 20 to 40. 20 to 40. Very good. Okay. Bipolar limb leads. Okay, bipolar limb leads. We got lead 1 that comes down. Lead 1 has a positive on the left and negative on the right. Lead 2 comes down through, ranging from the right down to the left. That's kind of your angle. You've got a negative up here at the top and a positive down on the left. And then lead 3, negative and a positive down on the left. Negative on the left and positive down on the left. So that's our bipolar. So lead 1, 2, 3. We already went through what lead 2 looks like. Now, I want you to think about lead 1. Think about where the positive is and where the negative is. And let's go through lead 1. So on lead 1, we have a positive over here, okay, and a negative over here. Again, think about this more abstract-ish, right, as opposed to definitive. So if we have lead 1 here, positive and a negative, and we're going from our SA node here down to our AV node, okay, what is our P wave going to look like? Upright or down? How do we look upright, right? Because we have coming here, we got a positive side here, this is negative, up here's a little bit negative. So positive going to a positive is going to give you an upright deflection. We have the AV node. We already know what happens at the AV node. Nothing. Okay? No electrical movement, at least initially. We have no electrical movement. Our PR segment is going to be the same as what we saw in our lead 2. Okay? The next thing we have for depolarization is what? You guys remember? Our interventricular septum. Okay? Our interventricular septum, which is also our Q wave. If we have depolarization of our interventricular septum and it goes this way, is it going to be downward or upward? I feel like I've got some answers. Does everybody agree? Down? Because we have positive going towards a negative. Okay, so we've got that positive depolarization going towards a negative. It's going to be a downward deflection for that Q wave. It should come back up here to baseline too. Come down and go back up to our baseline. Okay, so next we have depolarization. After interventricular septum, we have depolarization of the ventricular apices. Okay, so we've got depolarization coming down here, we've got it coming down here, but the majority is going to be pulled down here. Are we going to have a positive inflection for our R wave or a negative? Positive, right? Because it's coming this way. It's not going this way, it's coming this way. We've got that positive going towards a positive, which is going to give you an upright deflection. So that is our apices. The next thing we have is our ventricular bases. Our S waves here, S wave coming up here. If we have depolarization coming this way and depolarization coming this way, remember this is canted a little bit. Okay, this way up here, this way, is that going towards a positive or the negative?
Negative.
This is one that you have to like, I'll just go out and believe you, right? Because it is hard. Because this one definitely, this side definitely goes towards a negative, right? This one you can kind of say, I don't know. But trust me when I say they're both going towards a negative. If you put this on a cant like it's supposed to be, it's not going this way towards a positive. It's going back this way for depolarization. So that's going to be depolarization of ventricular basis, and that's going to be a downward deflection for our S wave. Our next wave is going to be between depolarization and repolarization, which is also called our what? ST segment. And ST segment is typically flat, and it aligns with our PR segment. The next thing we're going to have is repolarization. Repolarization, so we've got these cells turning from positive to negative. They're coming back up this way. Positive, negative, coming back up this way. Coming up towards the negative. So if you have negative for your repolarization, negative internal inside of those cells, going towards a negative, what should our next deflection be? Upright or down going? Upright. So that's our T wave. That should look familiar. What does it look like? Lead 2. Looks just like lead 2. Well, let's take a look at 3. Because when you look at 3, just looking like this, does this look familiar at all? Did anything else have a positive at the bottom and a negative at the top? Oh. Okay. I mean, lead 1 has a negative over here, but yeah, lead 2 definitely had a negative up here and a positive. So can we then probably anticipate what lead 3 would normally look like? Sure, we should be able to. We still have the SA node that's depolarizing, okay, depolarizing the atria. So when you have that atria depolarization, it's coming down towards that positive, because that positive deflection of our P wave, so atrial depolarization. We still have our PR segment. Okay, our Q wave is going to be interventricular septal depolarization, and it's not going towards the positive, which is down here. It's going this way. So the negative is up here, positive is down here. It's going this way towards the negative, towards where the negative area is. have our depolarization of our ventricular apices that is going down towards the positive, being pulled down right towards that positive electrode. That gives us a positive upright deflection of our R wave. After we have that, what do we think our S wave is going to look like? Is it downgoing or upgoing? If we have depolarization coming here and depolarization here, is it going towards positive or towards the negative? Going towards the negative. Negative is all up here. Okay, so it's going towards our negative, which is that downgoing S wave, then back to baseline. We've got our ST segment, which is flat, and then we have our repolarization. Repolarization. So if you have repolarization, negative going towards a negative is going to give you a positive deflection. So right now, what we know is lead 1, lead 2, and lead 3 look like this. The only thing that you'll see different on your leads when you're looking at it is the amplitude. Amplitudes, meaning how high up it goes or how far down it goes. So some will have a taller amplitude. Like lead 2 typically has a taller amplitude than lead 1 because of following the normal electrical conduction pathway. But we should have an upright P. We should have a flat PR segment. We should have a downgoing Q wave. We should have an upright R, downgoing S, flat T, and upright P. To some degree, you should have all of that. Okay? You shouldn't have an inverted P wave in lead 1, lead 2, or lead 3. That's unusual. That's abnormal. Something would be causing that. And what would be causing that means that the SA node is not your fire. That's not your main thing that's firing. Something is looking at those atria from below and firing it. And that's how the ECG is representing that. Okay, so when we look at lead 1, lead 2, lead 3, this is what we should see. It's just your amplitude is going to change from lead to lead. Now, again, these leads are looking at the heart from the positive electrode. From the positive electrode. So lead 1, positive electrode is on the left, negative is on the right. Lead 1, with your eyeball, is looking at the left side of the heart. Lead 2, positive electrode is down on the left, negative electrode is up on the right. Lead 2 is looking at what we call the inferior portion of the heart. And then lead 3, positive at the bottom, negative at the top. Lead 3 is also looking at the inferior portion of the heart. So far we have something looking at the lateral, okay, the left side lateral, and 2 looking at the inferior portion of the heart. Ooh. Aha, let me see here. Deloach. Deloach. Oh yeah. Okay, sir, what do you think? Fact or fiction? Fact or fiction? Heart disease affects only older adults.
Oh, that sounds like fiction.
That sounds like fiction. Oh, yeah. There are people that are very young that can have.
Oh, don't.
What? What's that?
Oh, I got nervous.
You got nervous?
Yeah. I'll probably eat it, that's why.
Okay, what about Nito? Okay, sir. Cardiac arrest and heart attack are the same thing.
That sounds like fiction as well.
That's false too, because we already said that. Remember, heart attack is dead tissue. Ischemia is decreased oxygen. Oh. You're gonna have to work on the catching game. Okay, we got one more here. Wade.
Looks like fiction to me now.
Another fiction. If you smoked for years, you can't reduce your heart disease by quitting.
It's a fact.
Matter of fact, if you stop, here you go, sir. If you stop smoking,
Thank you.
within 1 year, do you know how much you reduce your risk of heart disease? 50%. 50% within 1 year. 10 years of stop smoking, you're back to as if you never smoked. And I bring these out because I know you guys are the answers, but your patients are going to come to you and be like, well, there's no reason for me to stop smoking. I've already been smoking for 30 years. Well, not really. And part of our job as PAs is to have these conversations with our patients that don't really want to have these conversations. Right? Hey, I noticed that you smoke. Yes, sir.
Man, is that smoking specifically or all nicotine products?
I don't know. Because I don't know about vaping, and I don't know if we even have enough literature, for vaping. And then, if you think about like chew, I don't know that it causes much more oral cancer than it does. So this study that I reference is specifically associated with. We have to have those conversations with our patients that don't necessarily want to have them, but we eventually have them. Okay. All right. Lead 1, lead 2, lead 3. Bipolar limb leads. The other 3 limb leads are unipolar, which means they have only the positive, and then the ECG machine makes up the negative. Okay? And that's important because we still have movement of electrical activity going towards that electrode. We need to know how that's going to be represented on the ECG machine. So augmented vector right. Augmented vector right has a positive electrode built in, and that electrode is positive on the right side, and then the ECG makes up the rest of the triangle by putting a negative on the left and a negative on the right. We've got positive here and negative here. So this is AVR. Have we seen anything that looks like this, where we have positive up top and negative at the bottom? I feel like maybe we're going to learn something new. Okay, well, let's see what we're going to do here. We've got our SA node, and we come with positive going, that's our vector, electrical vector. Okay, we've got our SA node that's going down towards the AV node. So if you have SA node going down towards the AV node, depolarization is going here to here. This is our negative. It's going towards the positive, it's going towards the negative. It's going towards the negative. If we have positive depolarization going towards a negative electrode, how is that going to affect our ECG? What's it going to look like? Down going. So look at our P wave. Our P wave, which is representing that atrial depolarization, is down going. All right, before I click the button, next thing we know at the AV node, do we still have a slight delay, even though our P wave is down going? Still have a slight delay. We're still going to have that PR segment. That's going to be flat. Still going to have that node net movement because we need to have depolarization going from the atrium down to the ventricle, but not at the same time that slight delay. Okay, so now we have depolarization of the interventricular septum. Comes down here. The depolarization of the interventricular septum comes off the left bundle branch, and it's going to be depolarized this way. If we have depolarization that's going this way, we have a positive electrode here. Is our next deflection upright or downward? Up, up. Does anybody say down? Y'all cannot be tired already. We just started. Upright deflection. Because we're going towards the positive. So Q is going to come up and it's going to come down to baseline as well. Okay, what's next? Depolarization of the ventricular apices. So depolarization of the ventricular apices, a little bit of pull here, a little bit of pull here, and a lot of pull here. It's going towards the positive or the negative. Going towards the negative. And so if we have positive internal cells going towards a negative electrode, are we going to be downward, downgoing, or upward? Be down going our way. Our way comes here, and also comes back to baseline, so it's down going. After we have depolarization of the ventricular apices, we've got to have depolarization of the ventricular bases. So if this comes up this way, and this comes up this way, going towards a positive, do we keep going down further, or are we going back up toward our next deflection? Positive towards a positive is positive. And So really, this S wave many times actually comes back up above baseline and comes back down. So you'll see the Q wave that's up, which is unusual, R wave that comes all the way back to baseline, and then your S wave that comes up. Sometimes your R wave just comes here, and then your S wave will come back to your baseline. After that, we have our slight delay between depolarization and repolarization, which is going to be our ST segment. Okay, once we have our ST segment, the next thing will be repolarization. Repolarization. If you have repolarization, it's going to occur in the same manner, but it's coming this way, up towards this positive. So if you have internal of these cells negative, and negative is going up towards a positive, then what are we going to have? Upward deflection or downward deflection? Downward deflection, that's our T wave. Our T wave is our repolarization, and because of the nature of how these electrodes are placed in AVR, where you have the positive here and the negative down at the bottom and on the left, everything that we know from the rest of our bipolar ring leads, the 1, 2, 3, is an opposite because of the placement of the electrode, because of the how it's designed. So it helps us look a little bit more at the right side of the heart. As a matter of fact, there's really no electrode that gives us a great picture of the right side of the heart. But this does the best that we can have, because there's nothing else that looks on the right side. Okay, so AVL, augmented vector left. Augmented vector left, we have a positive here and negative here. What else looks like that? Lead 3. Lead 3 looks just like that. Positive here, negative here. ECG machine is creating the negatives. Inside that electrode we have the positive. And so this looks just like lead 3. That means when we have the electrical reduction, it's going to follow the same reproduction on our ECG paper. We're going to have the positive electrode, the positive inflection, and the negative inflections, just like we see in lead 3. And so if you go from your SA node down to your AV node, it's coming towards your positive. That's going to give you a positive inflection of that P wave. If you go around that AV node, we still have our PR segment. Our Q wave, ventricular depolarization, is going to come over here to the left. Okay? Over to the right, but over towards that negative. If it's over towards the negative, it's positive to negative. And we do that downward deflection. What does our R wave look like? R wave's coming all the way down here. Okay? Our depolarization for the ventricular apices is coming down here towards that positive side. Gives you that upright deflection. S wave is coming back up this way. Negative deflection, and then we've got our ST segment and our T wave. So this is going to look just like we saw in lead 1, lead 2, and lead 3. Okay, what about your augmented vector inferior, or AVF, augmented vector foot? It's down towards the foot. Does anything else look like this, where you have a positive here and a negative up here? Lead 2. Lead 2 looks like that. So it's going to be represented on our ECG paper, the same deflections that we saw in lead 1, lead 2, lead 3. Okay. Augmented vector right. We look at how augmented vector right looks at the heart. The positive is on this side, and the negative is on this side. So it's going to be looking at the heart from the positive side. It looks at the heart from this side. So it kind of looks here at the right side of the heart, and looks at the very top portion of the interventricular septum. AVL, the positive is over here on the left side. So it's going to look at the lateral side and the left side, and what we call the lateral side of the heart. And then AVF, our positive is down here. Look at our positive down here. It's going to be looking at the inferior portion of the heart. We've got those 6 limb leads. 3 bipolar limb leads, 1, 2, and 3. We've got the 3 augmented leads, ABR, ABL, and ABF. This tells us about the frontal part of the heart. Okay? The frontal part of the heart. Not through and through like this, the frontal part of the heart. That's the plane that we're looking at with these limb leads. So all of them except for ABR look just like this. And how does ABR look? Opposite of that. So inverted T wave, upright S, inverted R, upright Q, upright S, and then inverted T wave. So it's the opposite for ABR because of where the positive electrode is located on ABR. And how these look at the ECG, when you put them all together, we've got the ABR up on the right side, looking at the right part of the heart and the top portion of the interventricular septum. So now we have the ABL and lead 1. ABL and lead 1 are both looking at the lateral portion of the heart. And then we have 3 leads looking at the inferior portion of the heart. We have lead 2, we have lead 3, we have lead ABF. Because the positive electrode for those leads is located down on the left side. That makes sense? Okay. We'll go through this and then we're going to take a break. All right, chest leads. So we just said that the limb leads look at the frontal part of the heart. The chest leads look kind of horizontal, look through the heart. We have 6 chest leads, and they have to be placed at specific spots. On the wires, it's going to say V1, V2, V3, V4, V5, V6. That's all it's going to tell you. You have to know where they go. Right? The other one says right foot, right arm, left arm. Okay, I can figure that out. But this just has the number, has the V's and the 1, 2, 3, 4, 5, 6. So V1, right side of the sternum, 4th intercostal space. You try not to put it over the rib because that rib is bone. It's hard to conduct electricity through that rib. V2, left side of the sternum, 4th intercostal space. So you're just going right across from it. The next thing you're going to place is lead 4. So we're going to hold off on lead 3. We're going to place lead 4, 5th intercostal space. So go down 1 intercostal space, and it's mid-clavicular line. Mid-clavicular. Right here. Once you have V4 placed, then we're going to go back and place V3 halfway between V2 and V4. Halfway between. Next, we're going to go to V5. V5 is 5th intercostal space. That's going to be the anterior axillary line. And then V6, 5th intercostal space, mid-axillary. So we're only using the 4th intercostal and the 5th intercostal space. We start on the right side, 4th, go to the left, 4th, go down to mid-clavicular, come back to your V3, or in between your V2 and V4, and anterior axillary and mid-axillary. That's what we have. It looks at it from the horizontal view of the heart. Let's go ahead and take a break and then we'll continue.
These ones plus 3 more, or plus 4 more. Yeah, because that's how they come out on the paper. Or on the computer. Each thing is called a lead.
Yeah, it's coming, but that's why I feel like I got it from
I liked it, but then I was like, if I gave you something, I was like, what wrong with things about me offended? And they said, yeah, like Bud Light people. So it died, so I'm just like, if I'm next to my so I just kind of like stood around smart people and broken knowledge about, I don't like the all that stuff. But yeah, like I've done like, this is
They say, you see this thing on this paper? Do it.
yeah, so it's like, they don't teach a lot of stuff, like, one that she said earlier, like,
So ABR, LDF
like having,
so it's like, it takes one hand and then like adds the two together.
like, yeah, I thought doing like age tracking and stuff, like, they never really told that.
Like within the one.
They don't really have it looks like. Yeah, I know what it looks like, but they don't really talk about it.
Yeah.
Did they go for
Did it? Like,
some WPW dudes?
Yeah.
you're the paramedics, right? Did you plan to go to the one?
I spot a bunch of stuff. Yeah, I was like, no gas.
That's
gonna get that tomorrow.
The class I want to flight, just because like we got in. He's like, yeah, it was like $5 people in my class. I'm like, oh, okay, so just record your fees.
It just depends on what floor.
So red green.
Yeah, that's the one.
So I can do it. So like when you're red green colorblind, it's not like you can't do it's not red green just means crazy. Green, red, green. Not really bad. Yeah, like I passed because of the airport. I passed that. I can see. But my red's like terrible. Like I only see 10%. My right eye is 0.
Somebody who's red green, he's able to be fine.
I think that's just whenever your flight surgeon. It wasn't a flight surgeon. It was like I was flying out of hood, so like I went to like they make you start phase 1 at like one clinic. And you do like all like the stuff and lab work and optometry. They do optometry. I build it, book tests, and all of it like 2 out of like 25 grades. And then I'm like, all right, we'll do the second test, which you told me after surgery, we'll never do. And even all that, 1,000 waivers, even like the chief flight surgeon, I'm really like Rutgers looks like no. Like I literally I got a call from the chief surgeon and like he's like, hey man, this is going on. You can put the waivers in. So I called them and they're like, yeah, doctor, go through it.
Tomorrow's like 3
Yeah.
Because there's all very questions, so like it's yeah, class.
Yeah, so like I needed class week. Like yes, I knew what I needed. I needed class week off.
That's funny if they just gave you class.
No,
because
I can still go on there. I big fat fail. I'm like whatever. I tried. They couldn't take it. But like you're not doing that. Oh my god. It's even harder for you. Like, there maybe like smaller maybe. Yeah. It is for me because like a hood is all good. So like I was like, same thing with all like it's not. Dude, I studied this for years. You don't use it. You'd be like for me, like I would even get it back every time I recertify for reasons. Like my last job was operations. I have to do memorandums. Yes, it started to go on. Oh, sir, you remember the names, right?
A lot of them take that
I just guess the conceptualized meant like the things
like they'll have one that just
like the wires are ideas, but like the wires are ideas, like it's just doesn't click in my head.
Just the wires are structure, right? If the wires are sticky don't matter. The wires have to be on there, right?
or not say you want to take a penny, right?
Right. That's what
Is there the stickies are like you just like stick them on before, and you just like take the second.
I think honestly, if they have availability at lab like if they have days that work better for our schedule.
I think they only
Oh wait, but you need to yeah,
they might have it, but I don't think
Lag is so they may have, and it all depends on the schedule. Yeah. But search should be like in theory can hop around, but like yeah. It's all about like availability.
I got that at 014.
Room infection, that's kind of hard to fly. Yeah. Like if it's like pop out.
they're already open.
Yeah. What time? They haven't given me right. I mean,
You awake?
All those cards.
I'll do it.
we have it. Oh, that's final. Oh, yeah.
And then I asked them, if it's any lab.
No.
I don't care.
AVRs.
I was going to ask questions. They're all the same except for the ADR. Where is the negative? I guarantee it's gonna be this. Like this stuff. Yeah.
So what
Wave causes what, or what leads to what wave?
like, because I know the word like today, right? It's like, can't they use analyze and then like, we know we have to leave the year for of that. So like 2 weeks after, like, takes forever. Well, like, because that will be recording. Yeah, so then like, if you ask like, is that a possibility? Like, if there were not connections, it's how if there's a connection, all the users pretty often
When do you think
Like August 8th or somewhere in there. Because Sam texted me, he said, it's the 21st. How long is our spring break?
I know.
Yeah, Sam texted me, he said, you sure it's still first? I was like, I don't know, I gotta make it. You must have a 2-week spring break. That's why I only did a week on the map that I did. And then you just took the track off.
makes sense for the 14th?
August 4th to 6th.
Oh, our internet's working way better now. It's double the next one. Yeah, I think it's about double it. That's good.
EKG for you think about that. So I gotta make it to this one. You think about that.
My partner. Now you can. Oh, here. Oh, good. Cut off. Yeah, you and then he's the one who owns this iPad.
Where is the pacemaker of the heart located?
Pacemaker of the heart is normally or the SA.
Where is it located? Gotta make sure we know these calls on. Which precordial chest lead is located along the 5th intercostal?
I usually tell them, I'm like, I don't want you to think I'm rude.
B5 is. Hold on. It's not 1.
Fifth intercostal
It's
is
not 3.
is it along the axillary or the mid-axillary?
Mid-axillary. It's 6. Positive. 75-year-old man is complaining of chest pain. EKG is 10 shows changes in leads 2, 3, and AVF. What area of the heart is likely involved? 2, 3, foot, AVF, foot.
Okay, so we have our limb leads. Bipolar, we've got our augmented vectors. We know the only augmented vector lead, and out of all leads, we talk about the limb leads that's different is AVR because of the location of the positive. Those are our limb leads. We've got to talk about our chest leads. Our chest leads look at that horizontal view, so from front to back, not from top to bottom. When we place our electrodes, V1 all the way through V6, we start the right side of the sternum, we go to the left, we go all the way to the mid-axillary line. These are unipolar. They only have positive. That means that the ECG machine makes up the negative. When we look at these and we look at how this works, we've got our positive out here. Okay, these are our electrodes. And then these are how they're viewing the heart. So V1, and I've used the lower portion of the right ventricle, and then a little bit of the interventricular septum, and then V2 comes over, and then you can see V5 and 6 are up on the left side. Okay? So it views the heart kind of directly behind where that electrode is at, which is different from when we talk about our limb leads. The limb leads, electrodes are way out here, that's able to pull down and view the heart from this way, in the middle of the heart. Our generation of electroactivity. We're still pulling down here a little bit. So we've got our P wave. And our P wave is up here, our atrial depolarization. We've got all of our positives here, all right? So if you have your P wave up here and your atrial depolarization is coming down this way, it's going towards the positive electrons, going out towards the positive electrons. So you're still going to have upright P waves. We're still going to have that AV node that's having that slight delay. We're still going to have, when we get down to the interventricular septum, we're still going to have depolarization that comes down through here. So depolarization doesn't change, it's just how this is looking. And it's going in conjunction with our positive electrodes. We've got our ventricular depolarization that's coming down. Okay, the majority of it is coming down into the left, just like what we saw with the frontal view. And because it's coming down towards a positive, we're going to see that positive R wave here. This is our R wave. And what you'll see is as that R wave progresses from V1 to V6, it gets bigger, taller, higher amplitude. Around V5, so between V5 and V6, sometimes V6 is a little bit taller than V5, but a lot of times you'll notice that V5 is a little bit taller because once we get up to V6, we're moving away from that left ventricle a little bit, all the way up, and so we have a little bit shorter amplitude. But your amplitude in general will be this progressively enlarging or higher amplitude R wave. V1 is way over here on the right side of the heart. Okay? And so because it's way, kind of considered way away from the left ventricle, that's why we have such a low amplitude R wave. V2 gets a little bit closer to a higher amplitude. V3 and V4 are almost directly over that left ventricle. V4 usually is. And then we have that V5, V6. So our P wave, yes.
So is V5 right at the apex then?
V6 is more right at the 8, just inferior, and V5 is kind of halfway in between. So our P wave looks the same. Our PR segment looks the same. We've got our Q wave. The only thing that you're going to see different, we've got upright, which is pretty normal. That we're used to seeing upright R waves. It's just the amplitude of those R waves is going to change throughout the precordial leads. We did talk about with the Lindley slight change, but this is very obvious change. It's like, oh, this one's really short and this one's really tall. And you're going to see this progressive R wave. The other thing that you're going to see, we talk about the ventricular bases. These are our positives here, negatives up here. So what does that mean? What is our S wave going to look like? It's going to be downgoing or upgoing. We have negative up here and positive here. It's going to be downgoing, right? So it's still going to be downgoing. Is that normal? Is that what we usually see except for AVR? That's what we've been seeing, right? We've been seeing that. But the difference is the how deep the S wave goes from lead to lead to lead on your precordial leads. So, for precordial leads, we're going to see in V1 a much smaller R wave, but a much more prominent S wave. So, meaning we have amplitude up a little bit above baseline, but deep S wave. So, the S wave goes significantly below baseline. V2, up above baseline a little bit, the R wave, a little bit more than V1. V2, S wave, significantly below. Not quite as far below as V1. We have this progressively increasing R wave and progressively decreasing S wave. To the point when we get out to V5 and V6, you might have a little tiny S wave or no S wave at all. This is what your precordial leads should look like. R wave, R wave, R wave. But look at this amplitude as this is going up, and then around V5, you may see that V6 goes down because V5 is directly over that left ventricle, and the V6 is up a little bit higher. We have progressing R waves, okay, and then we can see our S waves get, this one going deeper, deeper, then they get shorter and shorter and shorter to the point that they have no S wave. And that's important to know because if you look at your V1, and that V1 has a large R wave in it, that's abnormal. You shouldn't have a large R wave in V1. You have to look and you say, well, wait, my V1 is large, my V2 is large, my V3 is getting smaller. That's reverse of what it should be. Something is causing that. Something in the heart is causing that to happen. And we'll talk about the pathology. We'll talk about what causes those things. But I want you to know, when you're looking at this ECG, for the normal precordial leads, we should have this progression of the R wave, and then we should have a decrease in our S wave as we come across the V5, V6. So prominent S wave in your V1, V2, and prominent R wave in your V5, V6. Yes?
Question, ma'am. Is there, this may be a silly question, but is there no Q waves in the pericardium?
In general, we don't see a lot of Q waves.
Okay.
In general. You can certainly see them, and we'll talk about reasons to say Q waves are okay and reasons to say they're not okay. In general, because of the amount of electrical activity it takes to depolarize the interventricular septum isn't a tremendous amount, sometimes that can't even be propagated to the EKG. But yes, you can see them. Okay? You can see them, but you don't often see them in any of the leads. If you see Q waves, we get a little bit more. So how do these precordial leads then look at the heart? Well, V1 and V2, if we look at V1 and V2, they're over the right side of the heart and kind of in through that interventricular septum. So V1 and V2, we think about those are our septal leads, looking at the interventricular septum, and then a little bit of that right ventricle. As I said before, there isn't anything that looks directly at the right ventricle. We don't get a good picture of the right ventricle. changing the way that we put our leads on. There's nothing but the best view that we're gonna get is a little bit of AVR, and then a little bit with V1, we can see a little bit of it. But I want you to think about V1 and V2, those are gonna be our septal leads. That's a primary thing that they look at. V3 and V4 are coming right up the middle here, right? And then we're talking about front to back, so that's the interior wall of the heart. So V3, V4 looks at the interior portion of the heart. V1, V2, the interventricular septum, or septal portion of the heart. V5, V6 are going to be over this left ventricle. This is our positive, so it's going to be looking at the lateral portion of the heart. Lateral portion of the heart. If we put all of this together, we know at the bottom, we use our limb leads. Those are primarily what we have at the bottom portion of the heart. We look from top to bottom, because they give us the frontal view of the heart. So top to bottom, we have 2, 3, and AVF. 2, 3, and AVF look at the inferior portion of the heart. 2, 3, and AVF. If we look at AVR, that's the only one that has a positive out there on the right side. That looks at the right, kind of the right side of the top portion of the interventricular septum. V1 and V2 is going to look at the septal portion of the heart. V3 and V4 look at the anterior. And then what do we have that's looking at the lateral? We already know some limb leads that look at the lateral. And then we just added some precordial leads that look at the lateral as well. 1, AVL, V5, V6. 1, AVL, V5, V6. All 4 of those look at the lateral portion of the heart. Why in the world would we designate 4 leads or 4 views to look at the lateral portion of the heart when everything else only has 1 or 2? Yes, and because the left ventricle, I mean, let's face it, if we didn't have left ventricle, we'd be in trouble, right? If we didn't have left ventricle, left ventricle really is the workhorse of the heart. So if there's something wrong with that left ventricle, we want to know about it. We want to know about it. For sure.
But along those lines, is that we only have one view on the right because we can expect most of the issues to be on the side?
Yes, yeah. I mean, to put it very simply, that is correct. We don't have a lot of right ventricular infarcts, but they can occur. But when, in order for us to look at those, we have to reverse how we're looking. We look at them from a different way. But the majority of infarcts or ischemia or issues that we have occur on the left side of the heart, or the lateral aspect of the heart. So we're looking at that with a lot of leads, because if that goes down, people can survive fairly well with a right ventricular infarct, but when they have a left ventricular infarct, that's not the case. So we put all of these together and they give us all these views of the heart. And we go back to this. We've got our 10 electrodes. That 10th electrode is going to be our interference electrode. And that's going to be on the right leg. So we've got our limb leads, left arm, left leg, and then right leg is our interference. And then you've got your chest lead or your precordial lead, V1 and V6. And then I would make sure you guys understand how to put these precordial leads on. I'm not going to ask you anything about the limb lead. That's too easy, right? You need to know when I ask you a question about where does V3 go, you got to know where it goes. Where does V4 go? You got to know where it goes. I will ask you a question about it. This is your regional map. You got to know this. You got to know this inside and out. Today, tomorrow, every day for the rest of your life. You've got to know this, because when you look at ECG and you're reading an ECG, you should put likes with likes. I don't read an ECG going lead 1, lead 2, lead 3, AVR, AVL. I don't read it like that, and you shouldn't, because they're going to be different. I read it 1, AVL, 5, 6. I put likes with likes. I want to see that entire portion of the heart, and what do those leads tell me about that part of the heart? 2, 3, AVF, V1, V2, V3, V4. I'm putting those together, and looking at those areas specifically together. Because if you don't, you look at 1, 2, 3, AVR, by the time you get to AVL, you forgot what you saw in 1. And certainly by the time you get to 5 and 6, you've completely forgotten what you've seen in 1 and AVL. So you've got to put likes with likes when you're reading these ECGs, meaning you have to memorize this inside and out, this regional map, so you know what's looking at what. This would be considered a normal sinus from a normal EKG. And I use the word normal kind of lightly because there's lots of normal variants, but this is as normal as we can get. Meaning, if we look up here at the top in our lead one, we can see that we have an upright P here. And we've got a little bit of space between our P and our R. That is our PR segment. Our R is upgoing, our S is down. Got a little bit of space here, that's flat, and then we go to our T. We come to our lead 2. Remember, lead 2 is one that's most along the electrical conduction pathway, and so it's the best view of our heart. If we look at lead 2, we see a P wave that's upright. We see a little bit of a Q wave here, got a PR segment in between. We've got our R wave that comes up, comes back down to baseline, a little bit of T, and we've got a little bit of a SP segment, and we've got our T wave here that's upright. So those are what we're used to. Let's look at lead AVR though. How does AVR look? Does AVR look as what we would expect? Meaning opposite of everything else? Sure, we've got an inverted P. We come up a little ditch over our Q wave. We come down with our R wave, which comes back to baseline. We've got our SC segment. We've got our inverted T wave. What we would expect. What about our precordial leads? Should we have a low or amplitude R wave and a significant downgoing S wave? Yes, we should. We should have that. So remember, in our precordial leads, you go from small R progressing to large R. You go from deep S wave progressing to almost no S wave. So we've got small R, deep S wave. A little bit bigger R, deep S wave. And now look at our round V3, V4 is going to be our transition point where we go from a higher amplitude R wave than a downgoing S wave. Meaning, if you were to count the boxes, 5, 10, 11, 12, there's more above the baseline than there is below the baseline. And what is our baseline? P, R, segment. Baseline. So you've got more above your baseline, and then let's look all the way over here to V6. Look at V6. We have R wave. Is that a good R wave? Okay, great. Okay, it's not very, but this person, their R wave, maybe that V6 was pushed up a little bit too high. Maybe pushed back a little bit too high. But we definitely see that progression here, here. And on V4, we start seeing a little bit of change with our S wave. So no S wave here and no S wave. Remember, 2.5 seconds, and then down at the bottom, 10 seconds. 10 seconds. When we use that 10 seconds, we use that for things like rate, like rhythm, because it gives us quite a bit of time that we're looking at that. All right, let's do a couple review questions here, and then we'll move on to our next lecture. Willis. Pacemaker or the heart rate, Willis?
Which one is? Which two?
Oh, Joseph.
Right atrium.
Right atrium. Pacemaker is located in the right atrium.
Buckets.
She's throwing dimes.
Yep, true. Everybody agree? Pacemaker is located in the right atrium as long as our SA node is firing like it's supposed to fire. Precordial chest lead, which one is located along the 5th intercostal space mid-axillary line? Avila, Neri Avila.
V6
Yep.
AM?
What'd you say?
V6?
V6, mid-axillary line. Everybody agree?
Yes.
V5 would be interior, V4 is mid-clavicular. Are you ready?
Son dying right now.
Oh, we got our V6. And then this is just a review. Okay, we talked about a lot of these things, positive, positive. And so just kind of keep that in mind. We've got our modified placement of our leads. Easy ones are the limb leads. It's got to say left arm, right arm, etc. And you've got to remember those precordial leads that come across. All right, we've got Palmer, Kenneth Palmer. Okay, sir, 75-year-old man brought in with chest pain. EKG shows changes in 2, 3, and AVF. What part of the heart is likely involved? Inferior. Inferior, right? 2, 3 AVF. 2, 3 AVF. Rain, Kyle Rain. Kyle Rain. Okay, sir, if I said, instead of 2, 3, and AVF, if I said V3, V4, what part of heart is that? We already know 1, AVL, 5, 6, lateral. All right, that's it for that. All right, we gotta move on. We are going to now, we talked about P wave, and ST segment, TR segment, Q wave, and all those things. We gotta put all that together. And we've gotta remind you, as we go on, what they do, what they represent, but also we'll talk about some specific parameters and we're associated with these different areas of the heart and these different letters that we're talking about. Here we got our TL. Did you have a question?
I was confused on the normal EKG, looking at the one that's the ABL. I thought that would maybe, I thought everything would be upward and not inward.
Yeah, so ABL, we can see that we have a little bit, we don't have a little bit of a P wave. Okay, it's not really very prominent at all. We've got a little bit of coming up. So anytime you have even a little bit, that's going to be an R wave. But yes, when you look at that, it's like, we don't have T wave inversion, we actually kind of flat T wave. And so that is a very good observation. It's still normal, so consider it normal, because it's nothing's inverted, but we would be thinking about why is my amplitude so small in that R wave and I've got more of a prominent S wave. So we can do the same thing when we look over here. You say, well, really this R wave should be higher up. And it should be. There are a couple other things I need to point out, but in general we think about, all right, if I'm looking at this, what am I looking for? So it's good that you recognize it's like, hey, is that supposed to be like that? It's still a normal variant, but yeah, we'd like it to look just like lead 2 or lead 3, right? In general, that's what we like. But yes, so this is just kind of a normal-ish variant. I've gone through multiple of these on here for normal to try to, every time I'm like, nope, I'm not. And so a student will be like, oh, what about that? I know, because none of them are really normal. They're normal, they don't look exactly like each other. Okay, so oh yes, we got some more factor fiction. Rogers Paulus, Alexander. Who? There you are. Okay, so what do you think? Green mucus, that means someone has infection. They need antibiotics.
That's fiction, man.
That is fiction. But do you think your patients are going to come in and describe their mucus to you and take a picture and say, look, this is what it looks like. I think I need an antibiotic. Well, how long have you been sick? 2 days. 2 days I've been having this. Green mucus does not mean anything. And there's multiple studies out there that say that. There's multiple studies that say it's really the cholesterol content. You know, I mean, what color are boogers? Green, right? I mean, unless you have the majority of times you're actually blowing out with green. Right? So we gotta talk to our patients like just the color doesn't matter. But we don't want to be mean about it. And we don't want to look at the pictures. They will show you pictures of the most amazing or not so amazing. Last week, I swear to heaven, I saw 3 people with worms. And every one of them had to show me the picture. And one, what happened? What did they do? They brought it in. They brought it in. They want you to believe them. Believe me, you know. So don't think about the fact that it's green mucus. What is the timeline that you've been sick? What are your risk factors? All right, generic medications. Rudolph. Rudolph. Okay, so generic medications are just as effective as brain damage. True. That's true. Watson? It is true. It is also true that some people cannot take generic medications because they'll have reactions to it, and thyroid medication is actually a medication that oftentimes people have to take the non-generic form of thyroid medication because the thyroid just doesn't respond as much as generic. But as far as effectiveness, supposedly they're all about the same. And then something my grandmother always said, always, getting the flu shot will give me the flu. Papa. Is it Papa or Papa?
Yes, ma'am. Tapa.
Papa? What do you think? I get a flu shot and we get flu?
No, it's infection.
Why is that? Is it inactive? No, it's inactive. Well, what? But there was a flu that had an active nasal one. Nasal, we don't have that anymore. So no, you can't get the flu. Which are the following ones? Lindley's, Griffin.
Are you talking augmented as well?
I'm talking.
I'm gonna say all the above. I guess 4 is interference.
I tricked you. Tricked you. What did I trick you?
AFD.
Oh.
Hey.
America's Funniest Home Video.
Wait, what?
It's ABF.
America's Home Funny.
Video. All right, 1, 2. We don't have 4. ABL. So A, B, and E. Yes. Fifth intercostal space, mid-clavicular line. What about O'Connor? Patrick O'Connor? Okay, what do you got? Fifth intercostal space, mid-clavicular line. B4. B4. Yes. All right, and then we got another scenario here. Shots. Rachel, shots. Okay, ma'am. 72-year-old comes in. She has hypertension, diabetes. She's got chest pain. We've got ST segment elevation in 5, V5, V6, lead 1, and ABL. Which area of the heart are we concerned about? Lateral. Man. We're good, but we're coming out. We already talked about this. You can come your positive Lindley. Okay, and then you guys know how to put it all together. Okay, now, EKG paper. EKG paper passes under pen 25 millimeters per second. Can you change that? You can change that in the settings. You can change that. Occasionally we will. But in general, it passes under paper 25 millimeters per second. Okay? And it's broken down into grids. Along the horizontal axis, we measure time. That's how we get that 10 seconds. That's how we get that 2.5 seconds as it's passing underneath that pen. Okay? The vertical axis gives us amplitude or voltage. And that becomes important when someone has a really high voltage R wave, right? Or really deep acid. Why would that happen? Why is it so big? Well, because we're getting a lot of electroactivity to that specific, from that specific area of the heart that's causing that voltage to extend above what we think was normal. On that horizontal axis, okay, we're going to use that horizontal axis to measure our rate of the heart and our rhythm of the heart along the horizontal axis. The box, like I said, they're broken down into grids. We have one small box, which is between the light lines here. That's one small box here, is 0.04 seconds, which means that one large box between the dark line and the dark line is 0.20 seconds. 0.04 for one large box is 0.20. For amplitude, one small box is 1 millimeter. One small box is 1 millimeter. One large box from dark to dark is going to be 5 millimeters, so it's 5 boxes. We've got 5 boxes coming across, and we have 5 boxes up. So again, when we think about amplitude, we're thinking about the strength of the amount, the strength of that electrical activity, the sum of the electrical vector, and how it's affecting the waves. It would be the P wave amplitude or the R wave amplitude. So how we would measure this, for this specific one, we would measure the boxes. We said 1 millimeter for one box, or 5 millimeter for 5 boxes in one big box. So we have 1, 2, 3, 4, 5. Another 5 here, that's 10. We have 1, 2, 3, 4. So we would say the amplitude of this R wave, which starts at the baseline and goes up to the tippy top, the amplitude of this R wave would be 14 millimeters. Okay, that becomes really important when we think about hypertrophy. So like enlargement of the muscle. If you have a bigger muscle, it's going to push up more electrical activity, more energy, and it's going to represent it in those two ways. This is our EKG paper. Down at the bottom, okay, down at the bottom, you can see where what the speed is set at. This should be all EKGs that you look at the bottom. It's going to be like kind of your, what's the word? Your table? Legend. Your legend. Okay, so this is set at 25 millimeters per second. We've got the limb leads of 10 millivolts here, okay, chest, okay, and then this is your approach that it's set up. We don't really mess with that. The only time we really mess with anything, again, sometimes we'll change the speed. And the reason why sometimes we'll change the speed is because, remember, we're talking about the horizontal axis. And sometimes the heart rate is so fast that we want to slow it down. And we can't, the patient can't slow it down. You're like, hey, slow your heart rate down. They can't do that. So we can do that with the paper though. So we can slow it down so we can figure out, is this atrial fibrillation, is this SVT, what's going on? We're looking for P waves and things like that. So that's about the only time we mess with the speed. Otherwise, usually when you get it, it's going to be set at a normal speed. If someone comes in, they have a super fast heart rate, you can't figure out what it is, you can then go in the parameters and change it, well, let's say 50 instead of 25, so 50 millimeters per second, and that will slow down beat to beat that you're seeing on your ECG. There are a lot of different tools that you can't use here, but maybe you can use in phase 2. I use them in phase 2. I use the calipers. So calipers are these things. They have little really pointy ends on them. They usually come with a cover, but that cover always falls off, and next thing you know, that thing pokes out of your backpack and it's your back. So just be careful with those. But they're really good for trying to identify if you're looking at an ECG and you're like, I don't know if that's regular or not. We can take our caliper and actually measure from the top of one arm to the top of the other arm, keep them like that, move them to the next one. Move them to the next one. It helps us identify if there's a little bit of irregularity. We have an ECG ruler. ECG ruler has a lot of different things on there. It has different numbers on there, and how do you, counting method for identifying the rate of the patient's heart rate. And then it has how tall a T wave should be, or a P wave, how long it should be, it has all that on there. Axis Wheeler rule, we will talk about axis and how to determine axis. And then this ruler here just makes it a lot easier so you don't have to memorize axis. We've got a lot of waves, we've got a lot of intervals, a couple of segments that we're going to talk about. We've already talked about quite a few of these things, so it should be pretty, some of these should be kind of a refresher for you. And we'll talk about some new things as well. Well, what is a nomenclature? How do we call these different waves or segments? We know the P wave is going to be that first upright portion of your ECG that we're going to see. That's your P wave, atrial depolarization. We've got our Q wave, which is going to be interventricular septal depolarization. That's your R wave, which is depolarization of your ventricular ABCs. The big S wave, depolarization of the ventricular bases. That's your ST segment, and then it's the time between depolarization and repolarization, and then our T wave, which is our repolarization. Sometimes you will look and you will say, well, I see my P wave and my PR segment. Well, why do I have two veins above baseline, two pointy areas? It looks like two R's above the baseline. That would be unusual. But sometimes you will see that. I want you to remember that the R wave represents depolarization of both the right ventricle and the left ventricle. The P wave represents depolarization of the right atrium and the left atrium, right? So sometimes when we see this separation of the R wave like that, it's because we have a delay in the depolarization. It's not happening at the same time. Something's causing a delay of depolarization of the right ventricle and the left ventricle. So they have a slight delay, and we can see that by having two R waves. Sometimes we have two S waves. Sometimes we have two R waves and two S waves. We really have a delay going on. There's something really going on with our electrical production that we're having now. But we can see that we have an R wave here. We also have another. So we have two R waves we call. One is the regular R, and the other one's called R prime. That's a little apostrophe up there. R and R prime. Same thing with your S. You can have S and S prime. Here we have R, and then R prime. But does anybody understand the difference between this top one here and this bottom one? Why doesn't this one have an R, S, R prime, and this one has R, S, R prime? It doesn't go below the baseline. You can see here R comes back down, but does not go below the baseline, so that is not an S wave. We come back up. This is difference in depolarization between your right and left ventricle. Here we go back down below the baseline, so we can get the depolarization of the ventricular bases, but then we come back up because we have that delay in depolarization. In the Garcia book, the Garcia reference, you will notice that you have mixed upper and lower case. Upper and lower case. And what that really means is that if you have a small R, it's a small R wave. If you have a larger uppercase R, it's a bigger R wave. That's all. You don't have to memorize that. Just know that it doesn't mean anything. Who cares, right? Who cares if it's a big one or bigger? I don't care. We don't care. We know if you have two of them, we want to care about that. But how they put them, if it's a big R or lowercase r, it doesn't really matter. Typically, if it's less than 5 millimeters, they'll use the lowercase. If it's greater than 5 millimeters, they'll use the uppercase. We talk about these as well. But this is the different things that you may see, and you got to know this nomenclature: R, R prime, or S, S prime. It's an example of our R, R prime, or R, S, R prime. You can see that we come up above the baseline a little bit, less than 5 millimeters, it's a lowercase r. Okay, down below the baseline for our S, we come back up above the baseline. So we have R, S, R prime here. Here we have RSR prime, and this is right about 5, so that's going to be uppercase R, uppercase R. And then here, what is this one? This is R prime. We don't go back down the list. We know that P wave represents atrial depolarization. It is the first wave of a normal ECG. And when we look across on the horizontal pathway, it's going to represent the time that our P wave takes, or our atrial depolarization takes. The normal duration for depolarization is typically less than 0.12 seconds, or 120 milliseconds. And that is equal to 3 small boxes, because 1 small box is 0.04, and 5 boxes is 0.20. So yes, are you going to have to know all these numbers? You are going to have to know these numbers. Okay? Because in real life, you have to know these numbers. It's not, you have to be able to, when you read the top, okay, it may say 120, you're like, well, what does that mean? You got to know what that means, right? And so the normal duration for the width of that P wave should be less than 0.12 seconds. Amplitude for the P wave, 0.5 to 2.5. Amplitude is how high it goes above baseline, that voltage. 0.5, so half a box, all the way to 2.5 boxes. If it goes above that 2.5 boxes, there's a reason for it. We've got to know what the reason. We've got to figure out what the cause is. Something's causing it to be too high. What? Something with the atria. Okay, so you need to know it's 0.5 to 2.5 is normal. It is round in shape because it doesn't require as much electrical activity for the atria to depolarize. The first portion of that P wave indicates depolarization of the right atrial, and the latter portion indicates depolarization of the left atrial. So again, if you have someone that comes in and they have right atrial enlargement, you're going to see that that P wave isn't rounded like it's supposed to be. There's going to be something abnormal. It's going to be more peaked. It's going to be more peaked at the beginning, and that's your indication that you have something going on in the future, because we should have a nice rounded P wave. Our PR segment, that is that slow depolarization through the AV node. It is measured from the end of the P wave to the beginning of the QRS complex. Okay? And normally, well, that's considered our baseline. Sometimes, okay, we can still be in the normal parameters. It can be a little bit depressed. And how would you know it's depressed? Because you're looking over here at the ST segment, and these guys should line up. So sometimes you can still be within normal parameters. You can have a little 0.8 millimeters of depression, which is a little bit off. Things like pericarditis, that will depress it even more, significantly below that 8 millimeters. Or we can have, if you have atrial infarct, which are pretty uncommon, it can be elevated in atrial infarct. This is our PR segment. We have something called our PR interval. PR interval begins at the beginning of the P wave and goes all the way to the beginning of the Q wave. And that measures the time it takes for depolarization to travel from the SA node into the beginning of that AV node. When we talk about PR interval, we have a normal duration for that PR interval. 0.12 to 0.20 seconds. 0.12 to 0.20 seconds means 3 to 5 small boxes. 3 to 5 small boxes. If it's greater than 0.2 seconds, that is considered prolonged. Things like AV block, first degree AV block, can cause a prolonged PR interval. Medication, call them the ABCD medication. So adenosine, beta blockers, calcium channel blockers, digitalis, all of that can prolong the PR interval. If it is less than 0.12 seconds, so 0.11 seconds or shorter, that is considered a shortened PR interval. And again, there's things that cause that to happen. Maybe our SA node is not firing. We're actually firing from lower in the atria, so it's not taking as long for that electrical impulse to get down to the AV node. So we have a shortened interval. Maybe we have an accessory pathway. We'll talk about accessory pathways. And also there could be a normal here. Let's take a break.
Remember on that thing when you're having trouble with it? I'm gonna leave my laptop here.
I don't know if I can go back.
You can't see.
Why are they saying that?
Even in normal marriage.
Still getting recognition
On the test, then
the reason why we have
EKG segment,
PR segment, is more due to this overall. So what the EKG is picking up is not just resistance. It's still coming down. We have that. So why would it be negative? EKG is not
No, I didn't get a chance to.
I guess it's not for another team. You want to try to
Yes. Potentially. Yes.
There's more owners who like left them.
But I'm trying.
Still get
Sounds like crazy cheese you put.
So calcium.
Still keep everything supposed to
Did it not go? Let me check. What do I do?
It's just go and come train the last when I was there all 30 years old.
I was like, you know what? I'm not even gonna get
I have an iPad.
Is it coming? just noticed it. Like, went out and then he made him like.
I think it's every time the socks off.
No, the morning was bad.
Oh, my God.
No, but it's really good. That's good though.
Cool, that's good.
Oh, yeah.
Hard.
Yes.
Like it was so wrong.
This is, I mean, just,
And I thought maybe it was working. But I think it was.
We're gonna go to Walmart.
It is? How many years?
10 years every year.
Oh, I had to wedding. It's a paycheck.
Yeah. We don't have, we got like 8 days before our first bill. Usually until day 6 to get out. Hey, look, what can we sell cards?
Nathan is.
Definitely cracking a cold white one when I get home. Cold white one.
Oh, yeah.
I'll blow over my chair.
Take you out.
This recording's got to be so long. It's already at 2 hours. And there's already another hour already to upload.
Too large. Probably stop it now and then start it.
Wow. Almost 9, dude.